morning, everyone. Thank you again, Rod, for giving me another opportunity to speak at this forum. So I would be reviewing the role of a ketogenic diet in the progression of a particular type of kidney disease called as autosomal dominant polycystic kidney disease. As already introduced, I can call myself a low-carb nephrologist, which I've been doing for last 4 years. I've been practicing for over 26, 27 years, but I think I wasted initial 20 to 23 years, and it has just changed my course correction 4 years ago. So these are my disclosures. I do practice and write prescription medication and sometimes speak and receive speaker fees from these pharma companies promoting certain new molecules which have come in the market for last 4 years. Now, coming back to the autosomal polycystic kidney disease, or ADPKD in short, it's a genetically mediated disease, and the prevalence of the disease is about 1 in 1,000 in general population. It affects younger people, and it runs in families. So apart from the index case, the parents could have been affected, siblings and children. It has a relatively predicted pattern of progression, so you can project when you are going to end up on dialysis. So the data suggests the majority of patients, over 75% of the patients suffering from this disease, would be on dialysis or requiring transplantation by the age 70. And this is characterized by formation of these cysts in the kidneys, and which gradually increase in size. They become fluid-filled. They compress the normal kidney tissue, leading to loss of kidney function, a lot of inflammation, and scarring and fibrosis. This is a CT of a patient who suffers from this disease, and you can see these large kidneys in the belly. They become so large they can occupy a whole of your abdomen. It's like feeling full pregnant all the time. So these are extremely large kidneys, and you can actually palpate these kidneys. So kidneys are usually deep-seated, but these are big kidneys, and the patient itself or the examining physician actually can touch and palpate these kidneys. So PKD is a systemic disorder, not only limited to the kidneys. So liver is affected too, and there are some cysts in the liver on the right side, above the right kidney. So pancreatic cysts are known, ovarian cysts are known, and sometimes patients can suffer from a brain aneurysm as well, and which is part of the disease syndrome. So I will present 2 cases. The first one is a 65-year-old teacher. She's still working, not retired yet, and she had a polycystic kidney disease for a long time. Her son is also my patient, and she has other family members affected by the disease. She has lost significant kidney function over the last 5 years or so, and looks like by the time she turns 75 to 80, she might land up on dialysis. Now, there is a drug available called tolvaptan, which reduces the progression of the disease, so it makes it slow. In severe cases of this disease, you can get additional 3 years of dialysis-free survival, which actually is a quite a significant improvement in our space, but it does not stop or retard or reverse the progression of the disease. And these patients, when they are on this drug, have to drink large amount of water because they pass large amount of urine. So up to 6 to 7 liters of urine. So you have to drink like 5, 6, 7 liters of water, and you keep drinking water and going to the toilet. So you just can't work, particularly someone with a teacher which have limited access to toilet. And she's currently seeing Amanda Sini. She's a dietitian sitting here. She declined the drug, and I said, go and see Amanda, see if you can reduce your carbohydrate intake and go into a ketogenic diet. The second case is interesting, and she lives in New Zealand and she sees a nephrologist there. She's 47-year-old and she's a screenwriter. She watched my low carb talk from last year and then approached me that if she can go on a low carb ketogenic diet. She has an extremely strong family history. Her father died at a very young age as a complication of the disease. Her sibling brother is affected from the disease. Her aunt received a kidney transplant, but subsequently died, unfortunately, from a complication. She's losing her kidney function. She's lost about 20 units of kidney function, which we measure as ml per minute over the last 8 years. And I could project that by the time she turned 60, she would have to spend her golden years of life on a dialysis machine. She's on that drug called Vaptan, which is standard of care. Now, this monograph shows how these kidneys gradually increase in their size. The existing cyst becomes bigger and bigger, occupying whole of the kidney, and the new cyst also starts developing at the same time. But interestingly, if you look at the top blue line, the kidney function remains preserved for a long time until they start to drop. Once they start to drop, there is a steep drop. This happens because we are born with about 1 million units in each kidney. Now, once the disease starts, it kills off some of the nephrons, and these nephrons pass on their work to the remaining units, which is, we call it as nephrons. And these units overwork, so they are stressed with work, and their GFR actually go up. Individual nephron GFR actually go up. So your total GFR actually remains stable for a very, very long time until the remaining units start to die off and the disease progress faster, and you see a steep decline in the GFR. So initial period of the disease, I call it as a honeymoon period, where the kidney function remains normal or relatively lower than the normal cutoff, but the kidney disease is progressive. Now, this study was a post hoc analysis of HALT PKD study, and this specifically looked at what's the relationship between the body weight and the progression of the disease. And what they found was patients who were obese and were suffering from ADPKD had a significantly higher progression of the disease as compared to someone who has normal weight. The second study looked at patients who had polycystic kidney disease and suffers from type 2 diabetes, which is a metabolic disorder. And what they found was the patients who had coexistent diabetes had a larger kidney. So kidney size is a very important marker. The bigger kidneys, that means the disease is going to progress faster. So these kidneys were bigger. They had more prevalence of high blood pressures, which is another risk factor for the progression of the kidney disease. And thirdly, these patients were dying younger. So clearly, it looks like the polycystic kidney disease is a metabolic disorder, and I will further allude to that in the following slides. Now, people have looked at the metabolism within these epithelial cells which are lining these abnormal cysts, and they found these metabolic abnormalities are actually similar to cancer cells. I first learned about the Warburg effect after reading Jason Funk's book on cancer code. So what happens is, this is our cell with the cytosol, and this is the mitochondria. We talked about a lot of mitochondrial health in the last few days. So normally, it's interesting to know that after myocardium, kidney is the next organ which has the highest density of mitochondria. And proximal tubule cells are also rich in mitochondria, and they depend on this process called as oxidative phosphorylation. So fatty acid undergo this TCA cycle, and one fatty acid produces 36 ATP. ATP is the energy currency of the cell, which is very efficient process, and the tubular cells live on this OXPHOS process in short. However, the abnormal epithelial cells, which is similar to a cancer cell, actually love glucose. So these cells feed on the glucose, undergo a different process called as aerobic glycolysis to produce energy. And this process produces only 4 ATP, so 4 versus 36. So it's a highly inefficient process. So why do they love this inefficient process of aerobic glycolysis? They are interested, the cell is interested in the byproduct of this process, including lactate, and the lactate changes the pH outside the cytosol. So the byproduct of this process fuel the growth of these cystic epithelial cells, including building blocks, building new cell structures, as well as new blood vessels to promote the growth of these abnormal cells, which is similar to cancer cells. Also, interestingly, these cells love glutamine. So they have a special appetite for glutamine. Glutamine is an amino acid, but is gluconeogenic. So it can be converted into glucose, and it impairs the oxidative phosphorylation, which is your normal process to make energy, and promote aerobic glycolysis, again fueling the growth of the cells. So Thomas Vimes is I think the leader, and he has been doing this work for last 20 years and predominantly in animal models. He's a professor of molecular biology at Santa Barbara University in California. And what he showed was through different dietary interventions that if you deprive the glucose to these cystic cells, and by changing their dietary intervention, you can actually inhibit the cystic growth and reduces the size of the kidneys. Now, they use different interventions, which included a mild calorie restriction, a time-restricted eating, and a ketogenic diet. So all these 3 diets actually end up with ketosis. So this is an interesting pathology, and if you can look at the kidney, the PKD kidneys, which this is the ad libitum diet. So over a time it progresses. These are the PKD kidneys. But someone with time-restricted feeding, the kidney sizes actually become smaller. When they further evaluated these patients from the initial study where they started with calorie restriction, they found that the patients, the experimental animals, their blood have high ketone levels, which is BHB, beta-hydroxybutyrate, the one which we commonly measure. They also showed that the cystic areas in these experimental animals, both male and female, the amount of cystic area is significantly reduced. And this is again a histology showing how the time-restricted eating improves the histology with much less number of cystic areas and more amount of healthy areas. So all these interventions led to ketosis. So they wondered, is it the specific dietary intervention, or is it the downstream effect of generating ketones responsible for the change in the cystic structure? So they ran another experimental study, which on rats and mice, they put them in 3 different groups. The first group received a weekly 48-hour fasting. The second group had a time-restricting eating of 16 hours of fasting and 8 hours of eating. And the third group, they did not change any of the diet. They were eating their normal chow, which is their feed, and they just added additional supplemental beta-hydroxybutyrate, and they found a similar effect. There was reduction in fibrosis proliferation, increased mitochondrial biogenesis. So supplemental itself worked the same way. Now, what they concluded that ketosis reverses the polycystic kidney disease in animals. And they ran another smaller study. What they did was the young mice or rats, which are predisposed to develop the disease, but not yet have the disease, the ketogenic diets actually prevented the development of the disease. So prevention and reversal, which is largely unknown in my chronic kidney disease practice. All the forms of dietary changes which induce ketosis prevented polycystic kidney disease. And BHB supplementation alone inhibited the progression of the CKD disease, PKD disease. So these cystic cells are metabolically inflexible. They live on glucose, but they can't metabolize fatty acid. So once you change the substrate from glucose to fatty acid, what happens is the lipid accumulates in these abnormal cystic epithelial cells. So they become loaded with lipids. They can't metabolize it. You have deprived glucose, and these cells undergo apoptosis. So these cystic cells, when they die, the cyst open, it releases all the fluid, and the cyst collapses. And that gives a breathing space for the normal tissue to expand. Now, these are about the animal studies, including mice, rats, and cat. But I treat humans, so let's talk about humans. So I mentioned about Dr. Thomas Wimes, but he collaborates with the other Professor Roman Müller. He's based in Cologne, Germany. He's a professor of translational nephrology. And they have a large polycystic kidney disease clinic. So these patients, they're coming into the clinic. A number of patients actually adopted a ketogenic diet on their own, looking at internet, Google, looking at low-carb sites, YouTube videos. And they became aware of these patients who have adopted this diet. So what they did was they retrospectively looked at the outcome in these patients. So about 131 patients, 74 were on ketogenic diet, and 52 were on time-restricted eating. Majority showed an improvement in their symptoms, overall health gains. 90% reported weight loss. Almost 64% reduced their blood pressure. 45 out of the 70 actually improved their GFR. Again, in our CKD world, even with that novel drug, you only slow the progression. Here, as similar to the animal studies, they're showing improved GFR, which is largely unknown. There is some adverse effect, including keto flu, which are like symptoms when you go from a glucose-based diet to a ketogenic diet. There were some lipid changes, and a small group of patients was on tolvaptan as well, but they tolerated diet as well. So it was a combined intervention. So this encouraged both Dr. Wimes and Roman Müller, and they embarked on a small pilot trial. They recruited only 10 patients, so 5 in the ketogenic diet, and 5 patients had to fast for 3 days over a 14-day period. So the study ran only for a fortnight, about 14 days. And what they showed was 90% of the patients could achieve a ketogenic state, and 90% mentioned that the diet as feasible. Most of these interventions, because of the restriction in your food composition, they become unsustainable, but 90% said it was feasible for them to do it. Within 14 days, they could see a significant drop in their liver size. Although the kidney size did not change in that 14 days period, it's a very slow progressive disease which progresses over decades. So we were not expecting any change in the kidney size. So the positive results from this study encouraged them to do in the next study, which was published late last year in November, called as Keto ADPKD. This was a randomized controlled trial, so which is a very high quality trial, an open label exploratory randomized controlled trial. So they took 66 patients and they were randomized to 3 different arms. The one arm was ketogenic diet. And mentioning this ketogenic diet is a plant-focused or plant-dominant ketogenic diet, not necessarily a carnivore diet. The second group of patients had to do a 3-day fast every month for 3 months. And the third group was controlled diet, living on a ad libitum standard American or SAD diet. They looked at the feasibility of this diet based on patient responses. They looked at the efficacy of this diet on the kidney outcomes, including blood pressure, weight, GFR, and the kidney and liver sizes. And they looked at the potential adverse effects. So looking at some of the results, patients in the ketogenic group lost about 7% of their weight. Patients in the control group actually gained weight during this process. The water fasting, there was no significant change. And when they looked at the body composition, there was a 20% drop in the fat mass. So majority weight loss was actually fat mass. And they further looked into it, and there was a significant drop in the visceral adiposity. I'm not showing that slide, but there was majority of the loss of visceral fat. Now, when they looked at the kidney volume, there was a trend, there was a reduction in the size of the kidney, but it did not reach statistical significance. The patients in the control group, actually the kidney size went up within the 3-month period. But when they looked at the liver volumes, there was a significant drop in the liver volumes within 3 months in the ketogenic arm, but not much change in the water fasting, and there was increase in the size in the control group. So looking at the changes in GFR, which was most impressive for me, in the ketogenic arm, there was a 5% increase in GFR. It's not stalling of the disease, it's not slowing the progression, it's actually improvement in the GFR. There was a drop in GFR in the control arm, no change in the water fasting. Then they used a different marker of kidney function called as cystatin C. So creatinine is muscle-based marker. So it could change with changes in the muscle mass. It could change with your meat intake, which is muscle anyway. So they looked at a cystatin-based GFR, and they found a similar results. In fact, the p-value even got better at 0.002 when they looked at the GFR changes based on cystatin C in the ketogenic group. So this again showing the same change in GFR. So the GFR in the red line continued to improve until the end of the study. After the end of the study, the patients went back to their standard American diet, and you could see the GFR dropped at 1 month post completion of the study. When they looked at the adherence or feasibility of this study, majority in the ketogenic group as well as in the water fasting said it's feasible. 0 is the neutral, which is everyday feasibility, and both ranked higher than 0. But ketogenic diet actually fared better than the water fasting group. Now, for looking at the adherence, the results clearly show these patients, given the weight loss, improvement GFR, that they were adhering to diet, but they used an objective marker. They looked at the blood ketones at every monthly visits, and patients have to check their breath acetone levels every day at home. They used a cutoff of 0.8 millimoles per liter of ketones in their primary analysis. That was their goal, but which is unusually higher than what we do in other studies. Usually the nutritional ketosis starts at a cutoff of 0.5. But when they used 0.8 millimoles, they found only 50% of the patient reached that adherence goal. So they re-looked at the data and lowered the cutoff to 0.6 or greater. They found almost 80% patient met that adherence criteria. So coming to the adverse effect, usually most common was initial symptoms of keto flu, like brain fog, tiredness, fatigue, and nausea, but which settled down within a week. There was some rise in uric acid, but no clinical gout. One patient developed a kidney stone or symptomatic kidney stone, which is likely unrelated because it was a short-term 3-month study. And there were lipid changes, including rise in serum cholesterol, LDL, neutral effect on triglyceride. This audience is very well familiar. And as Dr. Ken said yesterday, these lipid changes are likely energy transfer rather than anything else. So after the publication of this study, they did a post-hoc analysis of the same study, particularly focusing on the patients in the ketogenic group. There were 23 patients in that group. And what they did was they included a subgroup analysis of 19 patients where the BHB or the ketone levels was consistently greater than 0.5. So they removed 4 patients who did not have consistent BHB levels. And then they looked at the kidney size alone, and they found the change in the kidney size, which was a reduction, reached statistical significance at 0.049. They did another subgroup analysis of 19 patients where they looked at patients who maintained the BHB levels of greater than 0.5 plus a breath acetone levels of greater than 5 ppm. And they found the p-value got even better at 0.026. So take home message, my final slide. So ADPKD is a metabolic disorder. There's no doubt about it, given the underlying metabolic changes within these cystic epithelial cells. The various ketogenic interventions, they work in animal studies, and BHB is the likely downstream mediator of the effect. The human data is now available, including a retrospective trial, a pilot trial, and the small RCT. Dr. Mueller has informed that there's a phase 3 human studies are undergoing. It's called as Keto ADPKD Extend study. It is safe and it's feasible, and it leads to a reduction in the kidney size, a reduction in the liver size, significant weight loss, and improvement in GFR. In my personal experience, I've never encountered a drug which can do this. And I finally acknowledge Professor Mueller and Professor Wimes for your help. I was in touch with them while preparing for this talk for their inputs. Thank you again. Thank you for your time.